Good evening, everyone. Welcome to our event, a dialogue on the question, what kind of healthcare system should the U.S. adopt? Part 2. We had this question before us last week with a different group of speakers. Tonight, a dialogue between our two very distinguished guest speakers, two nationally and indeed internationally renowned economists, Amitabh Chandra of Harvard University and Tyler Cowen of George Mason University. My name is Edmund Santuri. I'm professor of religion and philosophy at St. Olaf College and Morrison Family Director of the St. Olaf Institute for Freedom and Community, the institute that's sponsoring tonight's event, which is the second of 2 panel discussions on the topic and the last of a series of 4 events sponsored by our institute this spring on the theme of freedom, community, and healthcare. The purpose of St. Olaf's Institute for Freedom and Community is to stimulate and support free inquiry and meaningful debate of important political and social issues among students, faculty, staff, and the larger public. By exploring diverse ideas about politics, markets, and society, the Institute aims to challenge presuppositions, question easy or comfortable answers, and foster constructive civil dialogue among those with differing values and contending points of view. For help in organizing our event tonight, special thanks go to Institute Events Coordinator Shannon Regier and Assistant Director Greg Seams. Thanks also to Jim May, Carrie Vanderveen, Andrea Galswick, Brianne Jans, Jeff O'Donnell, and the broadcast crew. The facilities team, Dana Thompson, our ever faithful student workers, Rebecca DeBoer and Mari Arneson. Professors Ashley Hodson and Jason Marsh, who are at the center of developing tonight's program, and all the students and professors of St. Olaf courses who are participating specially in our event this evening. I also want to thank those St. Olaf faculty who are part of a stimulating 3-session seminar on the topic of freedom, community, and healthcare. That seminar took place last February and March and was conducted in anticipation of Institute events on healthcare this spring. The moderator for our discussion tonight is Dr. Ashley Hodson, Associate Professor of Economics at St. Olaf College and a member of the Directors' Council of the Institute for Freedom and Community. She received her BA from Washington and Lee University in 2003 and her PhD in economics from the University of California, Berkeley in 2011. At St. Olaf, Professor Hodson teaches courses in principles of economics, microeconomic theory, behavioral economics, and most relevant to our subject tonight, courses in healthcare economics. Indeed, her areas of scholarly research particularly are healthcare, Medicare, and public health, and she's published a number of articles on specific topics related to those larger themes in a wide range of important professional economics and hospital administration journals. She's also been the leader of the St. Olaf Faculty Project on elder care, supported by the Institute for Freedom and Community. So I now turn the mic over to Professor Hodson, who will introduce our distinguished guest speakers and launch our panel discussion. Ashley?
Both of our speakers are economists, and they have encouraged me to be efficient and skip over the biographies that are in your bulletins. But I will say that when we invited them a year ago, both of them were really excited to meet each other. They've been reading each other's work for years. They're both distinguished in their fields and responded pretty immediately, just excited to think about these things together on this stage. So with that, I'm going to turn it over to Dr. Cowen to begin with, to give his perspective on the U.S. healthcare system.
If you want a 3-word takeaway for U.S. healthcare, I would suggest those 3 words are the supply side. Think back earlier to the 20th century, the great advances, antibiotics, vaccines, clean water, clearing out malarial areas, immense advances. Those kinds of advances are not over. There will be the next generation of comparable or maybe even greater advances, but getting those is the #1 priority. So healthcare, bottom line, the supply side, the pipeline of innovation is far more important than a lot of narrower questions of policy or narrower questions about health insurance or exactly when you can sue your doctor. So there's the general question, how can we make it easier for individuals to innovate This is and should be done jointly by government and the private sector, but innovation is a pipeline. It is tricky. There is no single pressure point where you can just, like that, and get more innovation. You need more freedom to innovate, you need higher rewards, but you also need quality safeguards and actual scientific procedures to make sure that people are not harmed. So the big question, how to improve the scientific pipeline, yes. Also a number of micro questions about the supply side. Immigration, should we let in more doctors? I say yes. Hospitals, so many people interact with the healthcare system through hospitals. Bad hospitals are terrible, they drive you crazy, often they kill you. We need to make hospitals better. There's too much market concentration when it comes to hospitals. Our National Institutes for Health encourages innovation. US is the world's #1 innovator. We should be spending more on innovation. It benefits the whole world, not just ourselves. If you want a truly egalitarian recipe for healthcare, it's actually in some ways to be wasteful. Throw a lot of money at things, most of it will fail, but whatever we come up with, most of the rest of the world benefits from. The FDA regulates new medical devices, new drugs. Some people have argued it makes innovation too costly, trials take too long. At the same time, quality safeguards are not exactly what they might be. So improving all those micro areas, and then just thinking about how we get more innovation. And here's a thought experiment. Let's say someone described a future world where you had new medical treatments and technologies, and some were very expensive, and they were distributed highly unequally, and a lot of people couldn't get them. And I say to you, is that a utopia or is that a dystopia? Most people say, oh, that sounds horrible. They're expensive, a lot of people don't get them. It can go wrong, but that is also a portrait of what success looks like. What success looks like is innovation outracing our ability to cover it or pay for it. And when innovation outraces coverage, you will get a lot of inequities, you will get a lot of high prices that people cannot pay. Over time, it will work out. But that is actually the ideal for innovation to be outracing coverage. Second point, another takeaway, public health is extremely important. So healthcare is not just about medicine or seeing the doctor or going to the hospital. It's both about how you take care of yourself and how we take care of public spaces. So basic questions about diet, exercise, smoking, obesity, critically important. The government's anti-smoking campaign, starting in the 1960s, was a major success, and furthermore, other countries copied it. It's harder to do this now. People trust our government much less. So I think a lot of problems of healthcare, they're actually trust problems or social capital problems. Congress's approval rating is often below 10%. Our president, no matter what you may think of him, is not actually ideally situated to lead a public health campaign. And we are in a world where public health successes can be harder to come by. Another major public health problem, also a social capital problem, is loneliness. Household size, smaller. Family size, smaller. Fewer people to take care of each other. Fewer wives to nag their husbands to take medicines. If you think that sounds sexist, there are research papers showing that married men are healthier for this reason. Otherwise, they do not take care of themselves. People not having big enough networks of friends. This is a major healthcare problem. Whatever we can do to fix this might actually go further than just focusing on healthcare more narrowly. But because of the trust and social capital deficit in our government itself, I don't think there are simple quick fixes. One problem we've had is we've had a lot of innovation in an area that's very harmful. Opioids is the most obvious example, but there are many other drugs, highly addictive. You can become addicted very quickly. Some of the innovation is you don't have to go to an evil, like gun-toting drug dealer to buy them. You use social media, the internet texting, and you buy them very safely, very cheaply. People are dying by the tens of thousands. There's not a quick fix in sight. Now let me get to the stuff everyone always talks about. I do have opinions on it, but it's not the most important questions. Most important are supply side and public health. Single-payer health insurance. In my view, it is most of all not possible, but at this point, not a good idea. We could talk more about this. Let me just make 2 or 3 points. Single-payer health insurance for this country might have been possible in the 1970s or earlier. Even then, I don't think I would have preferred it. I would rather have a system that spends and indeed wastes more money, so you drive more innovation and benefit the rest of the world more. But given that we've evolved so much employer-backed health insurance and Medicare, we have in essence a queued or tiered system. And single payer would break down those queues and tiers. In some ways, this might be more socially just, but the way American politics works, the notion that the elderly and kind of working middle class, upper middle class people with jobs and actually pretty good health insurance are going to vote or support something that puts them further back in the queue, in equal position in the queue with, say, people now who are either uncovered or on Medicaid. This will not happen. I do not care what your politicians tell you. It will not happen. In my view, pursuing it is counterproductive. You sometimes hear like, oh, American healthcare, it's laissez-faire. France has a wonderful single-payer system. Just keep in mind, as it stands now, per person, the US spends more through government on healthcare than France does. We spend some of it unwisely. Right now, it's not laissez-faire. It's a skewed, unjust system, but there's not any way to start it all over from scratch. People cite Canada. Keep in mind, for something like prescription drugs, one of the most effective forms of healthcare, highly valuable. US actually has far better coverage for people than Canada does on average. Canadian single-payer system has not really cured the public health problems, say, faced by many Canadian Indigenous peoples. This again shows public health is often a more important question than coverage. Briefly, Obamacare, what do I think of it? I don't have time in my allotted 10 minutes to go through all the pluses and minuses of a very complex bill. But I'll say this, the part of Obamacare everyone talks about, the exchanges and the mandate, I don't think politically made sense. Things get done in US politics when you have a good idea and you bury the cost and you trick people and you do it and you wake up and someday you say, ouch, but in the meantime you did the right thing. Obamacare piles the costs very visibly on people who are paying for the health care of others, and they identify, I'm the one who's suffering, paying the higher premium, and I know why this is the case. Obamacare was and is very unpopular, and I know all about the polls that say right now Obamacare is not that unpopular. I know those polls. No, Democrats lost every branch of government, in part, not the only reason, but in part because of Obamacare. Politicians on neither side are keen to repeat that kind of major change that imposes visible costs on identifiable people. Republicans voted 40 times to repeal the thing. And then they're in power, they control every branch of government. Do they actually repeal Obamacare? No, because they see what the Democrats learned. It's a kind of train wreck to try really big changes with American healthcare that take benefits away from people or make costs highly visible. So Obamacare, I don't think really worked out. It's actually mostly still in place. It's limping along. It's what we've got. It's not perfect. For some people, it's better. Like the actual margin of improvement on the issues people talk about in the newspaper, which are not the key issues of SupplySide and public health. But the real frontier is just to make Medicaid somewhat better, have Medicaid cover more people. It's not about single payer. It's not about Medicare for all. It's not about Medicaid for all. The actual frontier is Medicaid for some more, plus public health advances, plus those 3 takeaway words, the supply side. My time is about up, and now I turn it over. Thank you.
Dr. Chandra.
You have no questions to ask him? So I feel like I'm going to be the skunk at the garden party, so thank you for inviting me to this. But the reason I'm here, there are many reasons why I'm here. One is because I got to meet someone that I read almost every day on social media, to get to meet Tyler and dialogue with him in person. But the real reason that I'm here is because when I was an undergraduate, I studied philosophy and history and sociology and learned a lot about law. And so I'm very excited to be at a college that takes the liberal arts seriously, because at the end of the day, the answer to the questions that will be posed this evening lie less in economics and much more in your sense of social justice. And so I urge you to kind of engage with that in the form of the classes you take. All that said, let me tell you about how I think about the challenges facing us in the United States. On the healthcare side, I think that we and every major industrialized nation are grappling with what I call the healthcare trilemma. There are three related questions that we're trying to solve. One is, how do we cover people? So how do we get some kind of minimum insurance to 330 million people? It doesn't have to be, the same insurance for everybody, but we think that like medical technology today is a lot better than it was 50 or 60 years ago, and we would like more people to have it. So that's challenge number one. And that's the challenge that the ACA tried to take some baby steps on. And what it tried to do was it tried to expand Medicaid and give it to 20 million more people, and it tried to set up these exchanges and offer exchange plans to 10 million more people. So the ACA was a very small step on one challenge, which is the challenge of coverage. The ACA did very little on the second challenge, which is the challenge of quality. How do we make sure that once we've insured everybody, they get access to high-quality healthcare? Now, I'm familiar with this because I grew up in a country thousands of miles away in India where you can insure people, but it's not particularly valuable because healthcare is still deadly in countries like India. And so I don't think it's deadly here, but simply because people are covered does not mean that they automatically have access to high-quality hospitals and high-quality doctors. And the ACA does very little on the quality challenge. And then there's the challenge that almost never gets talked about, which is something that Tyler raised, which is the challenge of innovation. How do we cover people, give them access to high-quality healthcare, but continue to do that as new medical innovations arrive? It's actually very easy to solve two of these three problems. So it's actually very easy to think of solving coverage and solving quality and just ignoring the innovation challenge. That would be a very static solution. Other countries have pursued that solution. It is actually possible, it's not very expensive, to insure people in 2018 and give them access to high-quality healthcare. The problem is, fast forward to 2038, we will still be giving them access to 2018 healthcare. And that is a challenge that other industrialized nations are grappling with, right? How do we kind of get all three? It's also possible to do things like offer high-quality healthcare to people, offer and cover innovations for people who are able to afford those innovations and do nothing about coverage, right? So it's possible to do two out of the three. Very, very hard to do all three things. And so when we think about any proposal to improve American healthcare, we could call it the Medicare Act, we could call it a Medicaid expansion, we could call it Medicare for all, we could call it single payer. The way I approach the question is to ask, how do we do on these three criteria? Coverage, quality, and innovation. And a lot of these proposals manage to do well on coverage. They never talk about quality, or they use a bunch of hashtags for quality, like hashtag quality. And then they say nothing about innovation other than hashtag innovation, right? But as Tyler said, innovation is incredibly expensive. And if you end up paying for it, you actually make it harder and harder to cover people because coverage is more expensive. So that's the one way that I think about it. I think that the other reason that healthcare is so difficult and so much more challenging than fixing the market for cable television or fixing the market for cars or computers is healthcare is fundamentally about redistribution. It is fundamentally about giving access to people who may not be able to afford it. If we just wanted to do coverage for people who could afford it, you get employer-provided health insurance. It works incredibly well. It works for about 220 million Americans. There's about 100 million Americans who have to rely on public programs or go uninsured. So I think the reason it's so challenging is we have to think about what we're willing to do for people who are poor and people who are sick. And Tyler and I might be trained in the dark arts of economics, but there's nothing in economics that really tells us to agree on how much we're willing to do for the poor and the sick. He might be willing to do a lot more than I'm willing to do, which is different than saying I'm not willing to do anything. And because we don't really have agreement on how much we're willing to do, whether you call it single payer or whether you call it sort of private exchange plans or Medicare Advantage, there is always going to be disagreement, and that makes it really, really hard. Third point I want to make is, and this is related to something that echoes what Tyler said, there is a lot of confusion in the use of the words health healthcare, and health insurance. We use these three things interchangeably, but they're actually very, very different things. So health is not the same as healthcare, and healthcare is not the same as health insurance. Most of the debates we've had since 2010 have been about health insurance, right? But health insurance is mostly about reducing the financial shocks associated with being sick. There are ways to do healthcare without health insurance. We call them public health. Right? You don't really need to insure people if you just want to kind of give them health care. You could have clinics that don't require people to have health insurance that they could access in the absence of health insurance. But the thing we ultimately care about is neither health care nor health insurance. We care about health. And health is created by much more than health care. It's created by public health. It's also created by behavior. And behavior is like one of the single hardest things to change. Behavioral change is something that we love to talk about, but we don't really know how to change. So it would be really good to spend a little bit less time talking about health insurance coverage. It's important, but it's important in the end game. You know, it doesn't really get at kind of prevention and stopping the end game in the first place. And so my final point is that American healthcare, if it were its own country, so we spend about $3.3 trillion. If U.S. healthcare were its own country, it would be an economy larger than the economy of France. It would be the size of the German economy. If we are thinking about reforming the German economy in any direction, we don't think that 100 pages of legislation or 2,000 pages of legislation or a single industry, could be pharma, could be hospitals, could be insurance companies, is likely to be at the root of it. It is going to be a very complicated task, and we can talk about the complexities later on. But because US healthcare is so big, and government is the single largest payer in US healthcare, government opens itself to be lobbied. And then you get a raft of regulations that are ostensibly good, but actually quite harmful, because they end up increasing the cost of care without actually giving you a lot of health care at the end of the day. And so that's one reason that someone like me worries a lot about single payer. I'm not ideologically opposed to the idea of single payer. I worry a lot about taking something that I see as a problem, that government pays so much and so government can be lobbied so easily, and then saying we need to make government even stronger. That worries me greatly. I think there are ways to do coverage without single payer, and I'd love to sort of explore some of those ideas with you over the course of this evening.
All right, so both of you gave an overview of your basic position, but didn't necessarily bring up specific legislation. It sounds like, Dr. Cowen, you want small changes. You don't think the system can be overhauled. What would be the top few small changes that you would propose?
What counts as a small or large change is tricky. I would do everything we can on the front to have more innovation more quickly, keeping in mind that whatever we do spreads to billions of other people out there in other countries. And that, to me, is the number one priority of social justice. I would increase research and development, both the government and the private sector. I would take more chances. So in some ways, this would mean lower standards. I think we are playing it too safe when it comes to the FDA. I would allow in much more immigration of trained scientists, engineers, also doctors. I think of this as a market liberalization. On patents, that's complex, but I think we need to look at our patent laws again and make some patents tougher and other patents less tough. I would institute a system of prizes for important scientific advances, both from private philanthropy and the government. And most of all, I would simply refocus all of the healthcare debate so that 80% of what we talked about was, what can we do to boost innovation? Now, that could end up being a very big change. Will it all come at once? No. In that sense, it's a series of small changes.
So you say lowering the standards for what we qualify as innovation. Are you worried at all about snake oil problems, about innovations that enter the system that don't actually improve health?
I am worried about that a great deal. Keep in mind, right now, it can typically take $1 billion and 10 years to get a new drug approved. And that does keep out some bad drugs, as it is. Some bad drugs get through. But we don't see the drugs we never get. And there is evidence, if you look at what economists as a whole have written on the FDA, there is some disagreement, but the tendency is to think that current standards are too strict. You can, in fact, make it easier to innovate and have better standards. But I'm just saying, at the margin, I am willing to take more chances to get more of the drugs we never see. We're missing out on a great deal because we think regulation is making us safer. And in this context, it's far from obvious that is the case.
I also wanted to ask you about access. That was the first thing Dr. Chandra brought up, and you haven't addressed that. Is that something that's on the table for you? Do you have ways of addressing it, or is that something you'll let go by the wayside?
Here's a very good policy we did. If you think of people who are HIV positive and AIDS, it still is a major problem, but in the 1980s it was a much larger problem because we didn't know what to do about it. The way we tackled that was to throw everything we could at innovation. The FDA accelerated a lot of processes of approval. We spent a lot of money. People focused on innovation. And today, because of that, a coordinated public-private sector effort, if you are HIV positive in the United States and have a reasonable income level, your life expectancy is the same as a person who is not HIV positive. And those advances have spread throughout the world, not to everyone, but it's actually remarkable how many people in how many countries take advantage of offshoots of those drugs. So I do care greatly about access, but the biggest access problem is for something that doesn't exist. The best way to get access is really, again, to focus on innovation.
Dr. Chandra, would you respond to that?
So I agree with Tyler at a high level that we need more medical innovation, but my solution for more medical innovation is to signal to manufacturers that there is a market for their innovation. And the best way to signal that is to cover people who can't afford the drugs, is to say to manufacturers, look, we will pay for these drugs through the form of coverage. And I think that's the reason why we have cures for hepatitis C, but no cures for Ebola. I don't think the Ebola vaccine would actually elude Gilead scientists. It's just that there's no coverage for poor West Africans, but Medicaid will cover hepatitis C treatment. So I actually think we should be investing more in the NIH. We should be encouraging pharmaceutical companies through patents and exclusivity periods to bring new drugs to market, but that's not enough. And the reason it's not enough is, in a world with growing income inequality, pharmaceutical companies are chasing market size. They will build the kinds of drugs that benefit Tyler and me. So those will be drugs for Alzheimer's, Parkinson's, and cancer, which will benefit other people too. It's not like these are exclusively high-income diseases. They will benefit people in India and China as well, absolutely. But we also want, or I also want, innovation for diabetes, congestive heart failure, hepatitis C, hepatitis B, and a raft of other therapies. And if we don't cover people, which requires redistribution, we would effectively be reducing market size and giving a manufacturer 50 years of patent life, which is 2.5 times what they currently get, would be an insufficient signal for them to bring a drug to market. It would be a sufficient signal for them to bring a drug to market for the three of us, but that's not good enough. Now, I think that this challenge is going to become even stronger for a different reason going forward. So if we think about the great biotech companies in Palo Alto, California, and Cambridge, Massachusetts, many of them are on the eve of giving us cures for monogenic diseases. So in a couple of months, in a couple of years, we may have treatments that take on monogenic diseases, diseases that are caused by a single genetic mutation like cystic fibrosis, Tay-Sachs, Duchenne's, severe urea cycle disorders, and actually go in and edit defective DNA much like you would edit a typo with the word processor. It is going to be very hard to tell people in a democracy that if you can't afford those drugs, you may have to wait 7 or 10 years for those drugs to go generic. That is going to be very, very hard to do, especially when the drugs target genetic diseases. Edmund invited me. He's a philosopher. He's intimately familiar, as all of you, with sort of the sense of Rawlsian justice. There may be Rawlsian justice arguments to invoke, where and I'm not totally sure if I'm right about this, but society may have a very high willingness to redistribute money when it involves covering cures for genetic diseases, which is different than saying society is willing to cover treatments for diabetes and schizophrenia. It might be willing to pay handsomely for cancer treatments and some of these curative technologies. And the one thought I'll leave you with is, while it is true that Republicans are often associated with being the party of anti-science, the Republicans love the National Cancer Institute. And I think this has to do with some of the Rawlsian underpinnings behind generous cancer coverage.
Can you define Rawlsian?
I'll let you define Rawlsian.
All right, Rawlsian is maximizing the benefit to the person at the bottom, the person with the least resources.
But I was thinking Rawlsian in the sense of, that's exactly right, in the sense of like, we're all behind a veil of ignorance, where I don't really know whether my grandchild is going to have cystic fibrosis or Tyler's great-grandchild is going to have cystic fibrosis. And so I'm willing to spend for coverage of his great-grandchild, as is he mine, just because of this unknown risk, which is not true for everything else.
Okay. Dr. Chandra, you've said why you're against single-payer, but I'd like to hear more from you specifically about the kind of healthcare system you would implement.
So I think the ACA, for many of its defects, actually took steps in the right direction. At the end of the day, I do not believe that there is a single system that should cover all of us, simply because I look at this room and I see a bunch of students at the same college. You're dressed very differently, you take very different classes. Even if you come from families with the exact same income, your families probably live in very differently sized houses and drive very different cars. I find it therefore impossible to believe that all of you would choose the same healthcare plan or would want to choose the same healthcare plan. Some of you are more risk-averse than other people, and markets would recognize that kind of diversity in your preferences. So I like it that the ACA acknowledges that different types of people may have different preferences, that we may want to redistribute to folks who can't afford it. So I like a world in which you have Medicaid, in which you have Medicaid up to 138% of the poverty line, a world in which you have exchanges for people all the way up to 400% of the poverty line. I think a lot of people who are served by employer-provided health insurance, that's 220 million people. That's most of America. Most of America is quite happy with its generous employer-provided health insurance, and we should not dismantle that just because a third of Americans are behind dismantling it. And then there's Medicare for the elderly as well as the VA program. So I think reflecting the diversity of tastes, reflecting the diversity in incomes, we are going to have very different preferences for the kind of healthcare we want. And we want different plans to cater to those preferences. And so I think at the heart of the ACA, that design principle, that heterogeneity, variety is good, is something that we should stick to.
Okay. Every healthcare system involves rationing, and there's different kinds of rationing. There's wait times, there's global budgeting, there's multi-tiered systems. What forms of rationing do you see in your ideal system, and how do you justify that?
Is this for me or for him?
It's for both of you.
I don't think there's any ideal system. I don't think any healthcare institutions ever get fixed. Under all systems, at the end of the day, everyone is dead. How good a market is that going to be, right? People are not going to be happy with the final product. So again, when I think about rationing, the biggest rationing that goes on is what does not right now exist. If you think about Silicon Valley, what we would like to do is deploy the techniques of Silicon Valley more toward healthcare. Silicon Valley moves remarkably quickly. It's very dynamic. And the major reason they have not done more is fear of political confiscation of profits, of products, of property rights, simply being held up forever, time cycles for approval and implementation that do not mesh with Silicon Valley models of venture capital. Think of a company like Facebook. If it were a country, it would be the world's most populous country. It's only a little more than 10 years old. It went from nothing to what it is now. And if you're waiting on regulators for, say, 10 years, there are multiple levels of regulators. Your product liability you're never clear on. You're faced with the European Union regulations, a hostile environment from politics. The whole culture of your company becomes legal and bureaucratic and slow and public relations dominated. And that is not how great innovation happens. It's not how we discovered penicillin. That's the main rationing problem we have right now.
Dr. Chandra?
So I think the rationing problem we have is just, I'm going to restate the point I made earlier. I think that we don't get as many innovations as we could because market size is basically Medicare plus the employer-provided health insurance plan. So rather than sending a signal to manufacturers that it's 330 million Americans demanding their products, the signal they get is that it's 260 million Americans. So I think we've understated market size substantially by about 20%. 20% reduction in market size is a pretty colossal reduction in the amount of innovation that could happen. So my own view is that if we covered people generously for catastrophic illness and generously through public health for all the other things that don't require health insurance, we actually will get more innovation. And so the rationing that we're doing is that in our country, we've never had a conversation around whom to cover versus what to cover. We sort of cover everything for 80% of the population and then tell 15 or 20% of the population, you get the super cheap things that we can give to you for free. Maybe there's a world where we don't reduce anything on the 80%, but we spend more on the 20%, which is a form of investing in innovation. I would just call it a coverage expansion.
I mean, here's the difference between us. So I very much favor covering more people at the catastrophic level. We agree with that. But when we ask, why isn't there more innovation? You're citing the demand side. I'm saying the supply side is constipated. What I see is a world where there's a clearly acknowledged slowdown in the pipeline of new drugs. Everyone agrees that's slowed down. And if you look at total market size across new countries, emerging economies, even the US, market size has gone up a lot in the last 20, 30 years, and the pipeline is slower. So that to me suggests demand is not the problem, it's supply side constipation. I'm very willing to cover more people in this country at the catastrophic level, but why do you think that extra coverage is really going to fix this problem, which stems from the corporate and bureaucratic cultures of people we're expecting to innovate?
Here's the reason why. Because if you open up the R&D pipeline of all the big biopharma companies right now, today, they're doing research on about 6,300 different molecules, which are in phase 1, phase 2, phase 3 preclinical discovery. Between 1 in 3 to 1 in 4 of those drugs are oncology drugs. Supply does respond to demand. Pharmaceutical companies invest heavily in oncology drugs because oncology drugs are generously reimbursed by Medicare. They don't sit and invest heavily in schizophrenia drugs because there aren't payers for schizophrenia drugs. So my own view is that supply is not something that is only affected by patents and exclusivity. Even with patents and exclusivity, pharmaceutical companies will go after larger markets and pass on smaller markets. There's not enough cancer in the world to justify 1 in 3 to 1 in 4 drugs being oncology drugs. The reason that we do so much oncology research is because the US government is unable to walk away from oncology drugs. So by law, we have to cover every FDA-approved oncology drug. So that's exactly the market that you want to be innovating in because you know you have a payer who will buy your drugs. Oh, and then guess what? We don't negotiate drug prices, so this payer will cover your drug and not negotiate a price, which is why I do innovation in oncology. So I think that the supply is not at all constipated when you think about the parts of the market that it's responding to. Most people in the world will die of infant mortality, but there's very little innovation in infant mortality because the willingness to pay for reductions in infant mortality is actually small relative to the willingness to pay for incremental advances in cancer.
So you both heavily emphasize innovation. I want to hear from you what you think artificial intelligence and big data will do to the medical field in the next, say, 20 years.
I think we're potentially on the cusp of a lot of major advances. Just as a cautionary note, we heard this all in the 1990s, that the age of genomic medicine was about to arrive, and basically it didn't. There were many fine advances in the science, or you can send your stuff to 23andMe, but in terms of products that will help me, Tyler Cowen, live longer, it's mostly not there yet. That said, I am cautiously optimistic that some combination of machine learning and artificial intelligence and working with the genome will bring breakthroughs. But here's what I find striking. I mean, look at China, which is still a poor country. Per capita GDP in China is about the same as what it is in Mexico. And in many of these areas, it appears that China is ahead of us because they've been willing to take more chances, prioritize the supply side. China is a large market, though a poorer market. But I think if you look at how quickly they've leapfrogged us, you can see how defective, how bureaucratic, how slow our supply side has been. And that just should not be the case. I agree we've prioritized cancer drugs in a way that's unhelpful, but that too, as you stated, was an example of the government messing up what priorities ought to be. That's part of the supply side constipation. The law or the government, choosing some things over others, maybe for crony capitalist reasons or to appeal to voters. I think we're just falling down on the job, not just in medicine. In most areas of our economy other than tech, we are not innovating at a very rapid pace. Take the Amtrak train from Washington, D.C. to New York. I've done it my whole life. It is not better than in the 1970s at all.
Dr. Chandra?
So I'm less enthusiastic. I mean, I think there's a tremendous role for machine learning as a way to augment physician decision-making. I don't think it will ever replace physician decision-making. You didn't suggest that it would, but there is a tendency to think that machine learning will replace doctors completely. And I think the entire, sort of like how a doctor or nurse looks at a patient, records diagnosis, that's actually quite hard to do. I think physicians actually make lots of mistakes. They make lots of, mistakes of omission and commission. As they get tired at the end of the day, they might assume that the patient who comes in at 3 o'clock is likely to be suffering from the same disease as the patient who came in at 2:30. There's a bunch of, there's a raft of behavioral issues affecting physician and nurse decision making that I think we could improve quite dramatically through machine learning, where basically through gobs and gobs of data, I can provide doctors with additional information that their human eyes might miss. So an example would be pathology scans, EKGs are much better read by deep learning algorithms in computer science than they are by even leading cardiologists. So that's where I think the opportunity with machine learning is. There might be some additional opportunities with actually measuring performance of the delivery system. So there might be some measurement ideas or measurement initiatives where we start to figure out who are the better hospitals, who are the better doctors, and then tie payment to performance, where we've used larger data sets, used machine learning algorithms to mine those data sets and extract the signal from them. And then ultimately, though, we're relying on old-fashioned economics and price negotiations to steer patients to better providers. So I think that's the promise with it.
Let me just tell you why I'm more optimistic about machine learning than you are, or maybe at least a bit. If you think about the science of genetics, it turned out to be much more complicated than we thought. A simple trait such as height, which clearly is heritable. Taller parents tend to have taller children. Try to trace that. There is no height gene. There is a large number of height genes which are poorly understood. To unlock the puzzles of genomics, it does seem machine learning is extremely useful and starting to make very real progress on just helping us understand heritability. And I think we are on the verge of making major progress on that problem. In terms of machine learning improving on physicians, maybe somewhat, but it's really when it comes to genomics, cracking open the gene, that I see the potential.
All right, it's time to open to the audience. If you have questions, we have some microphones going around.
Hello. So this question is kind of for both of you guys. You talked a lot about what's feasible politically, but you also talked about things that are morally right, like letting in more immigrants. You made some arguments based on morals. You made some arguments based on political feasibility. One thing I was curious about is why you see a really robust and effective and efficient single-payer system as not feasible, or at least Dr. Cowen, you talked about decreasing monopoly power and breaking up some overly concentrated sectors of the economy. Why you see FTC action in that regard as politically feasible, considering that they're both government actions that could be stymied by lobbying. And I'm also curious how you make, for both of you, I'm also curious how you make the distinction between what's politically feasible and what and shouldn't be done if it's not, and what may or may not be, but is just worth pursuing on the merits.
Do you want it? Being tougher on approving hospital mergers, I think, is feasible.
Yeah.
I'm not sure it's feasible right this moment, but with a fairly typical administration, it's feasible. But the idea that you are going to ask Americans to pay the bill for what single payer would cost, and then say to everyone, either on Medicare or with private insurance, that their current favored position will be taken away from them, in my opinion, that will never happen. And if Bernie Sanders or another politician is out there, it is a recipe, it's a kind of full employment for Republicans act, more than anything else. You know, I lived in New Zealand. Single payer works fine there. It's pretty cheap. New Zealand doesn't innovate that much anyway. It's a small country. Single payer can work. There are other examples. It's not always a bad idea. Do I either want it or think it's even remotely feasible for the US? I still have to say no.
So I think it's wrong. I think it's wrong. You were right in your question to point out that it's wrong to sort of oppose a policy proposal simply because we think it's politically unfeasible. I think we should engage with the policy proposal. I actually do think it's politically infeasible, but in terms of the economic merits of single payer, I think here are the things that we're going to have to grapple with. First is the point that Tyler made. Single payer would require 220 million Americans who get their health insurance through employers and 45 million Americans who get their health insurance through Medicare to have completely new kind of arrangement because it's a different insurer. That's point number one. Second, we would have to trust the federal government to launch single payer when the federal government stumbled quite poorly at launching the exchanges, which only covered 4% of the population. Third, Medicare introduced a prescription drug benefit in 2006, 30 years after private plans had introduced that benefit. So the second and third points are just way of saying we have no evidence that government has a comparative advantage at running a giant insurance scheme. It may have other advantages like setting the level playing field, like regulation, like doing redistribution, but actually running an insurance program, as evidenced even by Medicare, is really not its comparative advantage. Fourth, the estimates of single payer say that the federal outlays for for single payer would climb to $4.1 trillion. It's about $1.5 trillion more than what the federal government is currently spending. The math behind how Senator Sanders wants to pay for it, he wants to double the payroll tax on employers, does not generate $1.5 trillion. It generates $700 billion, right? So he still has to come up with the remaining amount of money. What's his answer to that? His answer to that is, well, I can cut spending by $600 billion. Now let's work through the logic of cutting spending $600 billion. First of all, in the history of our planet, no country has ever managed to actually reduce spending on healthcare, and certainly not by $600 billion. What countries have managed to do is reduce the growth rate of spending, which is like saying, You know, if healthcare is 18% of GDP and it's likely to be 21% of GDP, success to economists looks like 20% of GDP. But it doesn't look like 15% of GDP. No country in the world has actually, including the NHS, been actually able to reduce it. So I think it's kind of fantastical and irresponsible to claim that we have figured out how to reduce $600 billion of spending, especially when you open up the plan, it says that there will be no cuts for the first 5 to 8 years, which means in years 9 and 10, the cuts will be 40%. Imagine going to doctors and hospitals today and telling them, you have to deliver insurance to more people with all the new innovations of tomorrow. It's got to be high quality care, but we'll pay you 40% less, right? Even if they want to do that, people like me, without control trials, are willing to say quality will not just suffer, it will hemorrhage in that kind of world. And then finally, we would be entrusting the government to figure out what is low-value care and what is not low-value care, which is an enterprise that it's been engaged in since the Affordable Care Act passed in 2010 through ACOs, through a variety of other initiatives, and they're not going terribly well. So at the end of the day, this is not, putting politics aside, an enterprise that I would ever bet on as an economist.
Other questions?
Oh, it's on. I would like to first thank you for coming today. I should stand up. It's the same whether I'm sitting down or standing up anyway. Both of you talked a lot about innovation. It seems like you're supporting innovation. You talked about quality. You talked about coverage, but I don't think we haven't heard enough about cost. So I would like to hear more about cost. The United States have not just the highest spending in healthcare, also has the highest growth. And at what point were the growth or the percentage of GDP in healthcare spending could be unsustainable?
So you might get different answers from us on this. You know, my answer is what makes it unsustainable is two things. One is really income growth. As long as incomes are growing, we will be able to afford to spend more and more on healthcare, as we should. As we get richer as a country, we ought to be spending more on healthcare. The extra utility of a third summer home and a fourth Ferrari is very small compared to the extra utility of an extra year of life. Even though, as Tyler pointed out, I might still die, it's still an extra year of life, you know? And so as we get richer, my sense is we will spend more and more on healthcare, and the constraint is really income growth. That said, we haven't been responsible at all in tying healthcare spending to our income growth. In the Medicare program, we're effectively borrowing from other countries and from unborn Americans. And so at some point, these countries or these Americans might say, enough is enough. Tie healthcare spending to income or income growth, but don't tie it to our paychecks because we didn't get any of these benefits. So I think that's the tension that we're wrestling with. It is entirely possible that there are a wave of innovations that come about that actually allow us to have better health at lower cost, and we should absolutely be creating the space for those innovations. In other words, not locking ourselves in to existing forms of delivery. If there are drugs that come in that displace hospital care completely, as Sovaldi did for hepatitis C, you know, if I have a cure for hepatitis C, I don't need interferon therapy. I don't need a liver transplant. Heck, I don't even need to see a hepatologist. I can just get a script for a hep C cure from a nurse or a physician's assistant. We always want to have a reimbursement system flexible enough to grab these new innovations, and we should not feel loyal to defending existing institutions that we've relied on for 100 years to give us health care. Because the day we do that, we're going to be spending a lot for care that isn't very valuable. And we certainly do a lot of that, I think, with hospitals in particular.
We agree on this 100%. I would just note to you all, he has a working paper in the National Bureau of Economic Research series that you can Google to, where he goes through how much of inflation in healthcare costs comes from aging, from population, from prices being higher. And I would recommend you read that. But I would second absolutely everything he said. And again, repeat the point. Healthcare costs are never going down. You can hope to make the trajectory less bad on the upside.
I have a series of questions. First one is, if we take healthcare out of the stock market, where people that are not involved in healthcare stop making money, do you believe that a single payer would be more effective? I mean,
No.
you said that $6.8
No.
billion.
No, there's just
Wait
no.
a minute.
No.
You said $6.8 billion that we needed to come up with. Well, there's $512 billion that is going to be built into a wall. Don't you think that that money would be much better spent on these young people right here?
Yes.
Okay.
We're not going to build a wall, by the way. We're going to say we will, and then we won't do it. And we'll waste a few billion and be idiots. It's not a way to fund healthcare, not to build the wall.
But, you know, I would also say something else, which is, I think we might agree on this. At the end of the day, economists do not struggle with the for-profit imperative in healthcare. We're okay with people making tons of money. I would actually want to live in an environment where the people who are the richest people in society are the people who've saved the most lives. So I'm totally okay with that. So if doctors and pharmaceutical companies are saving lives, I'm completely fine with that. And I think for the innovation that Tyler wants to see, we might want to give even more profit incentives.
I agree with you, but how about build a mechanic that just put $25 in there just to make a buck? And these people are struggling to try and make an even dollar because they're doctors, lawyers. In the meantime, Bill, the mechanic, is investing in the stock market and he's making money on the sweat of these people.
Look, one way to make healthcare cheaper is to allow more functions to be performed by physician assistants and nurses, to encourage the recent trend of retail clinics where you can walk in to a CVS or an urgent care. At the very least, it can be quicker or easier or even safer and often cheaper than a hospital. And you actually have a better chance in many of them of developing an actual personal relationship with a caregiver. This is already underway. There's more we could do. It's not going to solve the problem, but there are plenty of margins where simply natural progress already underway is making some things less expensive than they used to be.
Other questions?
Is this thing working? Okay. One thing I think doesn't often get addressed enough in healthcare economics is the impact in rural areas. So I had sort of a two-part question I was hoping I could pick your brains on. First of all, in the transition away from the pretty reviled fee-for-service model to quality reimbursement, do you feel it's possible to take into account differing socioeconomic factors and the fact that reimbursing a physician for the quality of the care and improved outcomes may not be feasible for some demographics or maybe more complicated? And then second, with increasing innovation, which you both mentioned, how do you feel we can accurately take into account the difficulties geographically in rural areas where, to afford the newest machines or cancer treatments, patients may have to drive 5-6 hours?
Encourage people to move to cities and populous suburbs. It's one of the easiest ways to radically improve our healthcare system. It actually works. Simple migration is highly underrated. You mentioned fee-for-service. You know, how deeply can we get into the not feasible? There was a 1990s revolution in managed care. I mostly favored that. It did control healthcare cost inflation. If there was a way we could go back to it, I would do it. Americans hated it. We love to spend money on healthcare the way we waste money on snowmobiles. I don't favor this cultural propensity. I like to think there's some world out there, distant, maybe imaginary, where with higher social capital, we save more and we're more responsible in how we spend, and that actually would improve healthcare a lot. It's not really a policy prescription, and it's like wishing for a magic wand, but still, I do sit around and I wish for it.
Cities are man's greatest invention. That's certainly true. So I'll give this shout out for cities. I think that, in a sense, medical innovation could be, novel medical innovation could disproportionately help rural communities because you're disrupting the need to be seen at a hospital or be seen by a doctor or a nurse practitioner even. So if we had a cure for cystic fibrosis, and think about how complicated that disease is and how often you need to be treated and go to a lung specialist. If one of these biopharma companies gives us a cure for cystic fibrosis, a 12-year-old child with cystic fibrosis will go on to be 82 and die of Alzheimer's, not needing any kind of local care at all. So again, I would bet on medical innovation, therapeutic medical innovation, but as well innovations like telemedicine to help rural communities a lot more than we have. I think what we don't want to do is allow rural hospitals to game the political system, as they're very good at doing. They'll come to the local state legislature and say, it is imperative that you help us out and allow us to survive, even though no one comes to us and they're all driving to the local hospital in Boston. Give us more money, because if you don't give us money, we're going out of business. Empirically, if you look at the performance of those hospitals, they're not very good. We'd actually be better off letting a bunch of them go out of business.
Just for a startling wake-up fact, life expectancy for the Amish, who do not use much health care, it's not forbidden, but they don't use much, it's the same as for us. And they are mostly rural. You look at behavioral factors and lifestyle, obviously there's more exercise, but they are doing very well with good individual behavior, very low levels of loneliness. Maybe their levels are too low for loneliness. But it's telling you public health really matters.
And public health does matter more, I think. It might matter differently in cities than it does in rural areas. And I think we also agree that public health gets underfunded in the United States. So I think we're both talking about innovation, and when we both talk about innovation, it's tempting to think of that as representing pharmaceutical innovation or procedural innovation. But what we really need is innovation in public health. So innovation in public health is hard to do because it's not incented by intellectual property. Like, you don't get a patent for figuring out how to help someone with their loneliness. And because you don't get a patent, there's like no money to be made there. And because there's no money to be made, as a society, we probably don't invest sufficiently in discovering treatments for loneliness. And that comes full circle, I think, back to this idea of investing heavily in the NIH, but encouraging the NIH not to replicate what industry is very good at. Industry is very good at giving us cancer drugs. We need the NIH to focus on things that the industry will not do, which is to take on problems like loneliness.
Here's the good news. Believe it or not, there are now Brussels sprouts that taste as good as French fries. Here's the bad news. They cost $30. Getting that price down is in part a healthcare problem. On that, I'm actually pretty optimistic.
Other questions?
Hi there. First of all, thank you guys both so much for coming to speak to us. So I know that you're both economists, but I have an ethical question for you both. So you were both saying how a single-payer healthcare system, you both were not great fans of it. You also mentioned you really prioritize drug innovation and place a high emphasis on that as well. But drug innovation also leads to very high costs. So picture a scenario, this is a very real one sadly, of EpiPens, and how EpiPens currently cost $500. You have to replace them every year, and a lot of single mothers actually cannot afford them for their kids. So I'm asking, many countries use single-payer healthcare systems so that the government can legislate or at least negotiate drug prices. And you've noted that that does come at the cost of innovation. But in a case such as this, is it more ethical for the government to intervene?
So I can talk about let me give you two answers. One on the EpiPen and then on the pharmaceutical price regulation. So the EpiPen is interesting. The EpiPen had a competitor. Sanofi had a competitor to the EpiPen. The FDA said that the Sanofi EpiPen, it was not the EpiPen, had some adverse effects associated with it. Rather than telling Sanofi that you need to make some manufacturing improvements and improve the product, they took the Sanofi product off the market. When they took the Sanofi product off the market went from being a duopoly to a monopoly. First lesson of economics, when you're a monopolist, you price like a monopolist. So boom, the price of the EpiPen went up as much as it did. So that was a colossal regulatory failure, and it was a regulatory failure caused by the FDA being a public health agency, only caring about safety but not caring about prices, and prices are central to access, and access is just like safety. If people can't access the drug because of the high price, it's sort of like it's as good as the drug not being built in the first place. So I think the EpiPen has some sort of unique economics that we do understand. I think as a result of that, I'm willing to call it I call it a mistake. I think the FDA is a much more sensitive to the kind of guidance that it gives manufacturers with sort of lower quality products. Okay, so now let's talk about pharma, and I'm very curious about what Tyler will say. Drug spending is about 15% of all of healthcare spending, right? So if you look at the total pie, the drugs are about 15%. The branded drugs are about a third. So the branded drugs are 5% of all of healthcare spending, but the branded drugs are where the innovation is happening. If we allow government to come in and negotiate the price of that 5%, in the short run, the government will get a much better price than insurers are getting. No question about it. And in the short run, many more patients will get those drugs. That's a big benefit, no question. But we have never seen a virtuous monopsonist. We've never seen a government price the drug low enough that people can access it and high enough that it still sends in an incentive to future manufacturers to build the drug. So my worry would be that the short-run thinking of government, especially when it's cash-strapped as a result of a tax reform or tax cut that I don't completely understand, that government will set an unusually low price. We will all get the drug. We'll all be very happy. And a raft of drugs that we really want to come to market that could disrupt hospitals and other parts of the system, help patients, will never come to market.
I second all of that. I would stress the point, every new drug we come up with spreads to the rest of the world, so let's not cut back, even if it hurts. But I would be willing to experiment with a system where a government buys out some patents at auction prices and then gives away the drugs cheaply. I'm not sure how much we can generalize that and how good a job of that our government would do, but I absolutely think we should make attempts in that direction, see how it goes, maybe do it some more. I don't want to oversell that, but we're not doing enough of it now, and it gets back to us being constipated culturally, socially, but most of all politically.
So thank you for an insightful discussion. But given the human condition that we have this propensity for unhealthy behavior, we're all going to be dead anyway, finally. And in the meantime, the medical needs, or at least the perceived medical needs, are a bottomless pit. I'm intrigued with, and I agree with the idea that innovation has to outstrip coverage. My understanding is that right now, with Medicare and Medicaid, which we presume should at least include a decent minimum of basic medical care, the criterion that they use is whether it's experimental or not. And of course, that term is both vague and ambiguous. And if we're going to allow innovation to outstrip coverage, which we have to given the human condition, I just wonder what kind of criteria we might use to distinguish between the innovative drugs that are available to those who can afford it and what's available as a decent minimum to everyone. I don't think experimental is going to do it, because we're going to have innovations that cease being experimental but are much too expensive to include for everybody. There's very good examples now of drugs that cost hundreds of thousands of dollars a year, but they are effective and they're beyond experimental. So you've thought about this, and I'm really genuinely interested in what kind of principles or criteria we can use to distinguish what's covered by for everyone and the innovative ones that are available to those who can afford it.
I'm not sure I'm sufficiently well informed on the exact point of your question, but let me answer something parallel. Looking forward, the optimistic scenario is that China innovates a great deal with pharmaceutical drugs and with medicine in general, with genomics. I think the chance of this is actually quite high. I'm very optimistic about China in this regard. That we digest those innovations smoothly and quickly is very important. I'm not saying we should automatically accept anything that is made in China. I would, with the European Union, have full, complete, and immediate reciprocity with new drugs. I would have a tougher standard with China, but I don't want a situation where something coming from China has to go through our procedures more or less from scratch. A lot of experimental drugs, techniques, medicines will be coming out of China, are coming now, and we need to think now, get ahead of the curve. How can we absorb them in a safe enough way, but still manage to absorb them? And I would wish that we would focus more on that problem.
So I also don't know that much about experimental drugs, but I'm going to interpret your question as being a question about how do we, in our public programs like Medicare and Medicaid, make sense of high-cost therapies whose value is uncertain. So maybe they were approved by the FDA, but that doesn't mean that they're better than the next alternative, because as you know, for the FDA to approve a drug, it just has to be safe and effective, but it doesn't have to be more effective than an alternative drug. So it's possible that a drug was approved, it does what the manufacturer said it does, but it might be the case that it is no better than the alternative, but the alternative is substantially cheaper. So how do we in Medicare and Medicaid, say no to some drugs? My own view of this is that in Medicaid, we should let the 50 states decide. I don't think we want a single Medicaid formulary because of the remarks I made when we opened this discussion. I think people in the 50 states have very different preferences for the amount of redistribution that they want to do for the poor and the indigent. And states that are willing to do more should have more generous formularies. In Medicare, which is a federal program, you might think, well, maybe we should have a single federal formulary which decides which drugs we cover and which ones we don't. I don't think that's a good idea, because that means Congress sort of decides everything, and Congress can be easily lobbied by the oncology monopoly one day and the Parkinson's disease monopoly another day. I think a much better idea in Medicare is to double down on the Medicare Part D program, which is health insurance for prescription drugs, and let the private Part D plans make their own formularies and allow patients to pick which formulary they want to be in. So if I'm a Part D plan and I create a very stingy formulary, and Ashley creates a very generous formulary, if patients go to her, then maybe hers was the better formulary. If mine was stingy and they come to me because they'd rather see the savings in their they get sort of a credit for picking the more stingy formulary, so be that. So my view is that in the public programs, we are going to have to do some cost effectiveness. I'd much rather delegate that decision to plans, private plans competing for Medicare dollars, than Washington deciding which drugs we ought to cover and which ones we don't, because it's not like Washington will be too stingy, it will actually be too generous because of capture by the industry.
So before this started, I actually sent the live stream link to my family, and at home, my dad, who's a physician, and my brother, who's a fourth-year medical student, they actually texted me a question.
Is it about medical malpractice?
So their question is, how do you see the differences in reimbursement between specialties such as primary care or surgical subspecialists changing in the setting of rationing cost as well as care?
There was just an article in JAMA suggesting the practices in America are not as different from the rest of the world as many people often suggest. The notion that America doesn't have enough GPs addressing the problems of younger people, I basically agree with that. And on net, any switch we can make, spending less money on the elderly and more on the young, more on infant mortality, switching dollars out of Medicare to Medicaid, I mean, most of those trade-offs I want to do. They're not the highest thing on my wish list, and I think they're politically tough. They're not necessarily what I would go to the mat for, but it's striking to me when you compare how our government spends its healthcare dollars compared, say, to France, which along some dimensions has a better functioning system. One of our big mistakes is I think we don't spend enough on young people and we spend too much on the elderly, and that is correlated with the issue of GPs. But I would reframe it as old versus young and to some extent wealthy versus poor, rather than being about specialists.
I agree with the sentiment behind Tyler's response to you. I think at the end of the day, I don't really care about the GPs or the specialists. I just care about the health that we get from the healthcare system. And so if we have another way to produce that health, it could be a drug, it could be a surgical procedure, I'll pay handsomely for that. So as long as we sort of don't try to micromanage this problem of specialists versus primary care and think about what is the health that a primary care physician produces, or maybe someone who's not even a primary care physician, a nurse practitioner, if we sort of pay for that value instead of the actual particular input, I think we'll be okay. That's not what specialists want to hear, but I think that's part of the problem, is that we don't want to keep the ossified parts of healthcare in business. We want to always have room for new entrants to deliver the same amount of health.
Hi. Okay, so I also wanted to say thank you so much for coming and everything. And I also have a family member who's a physician, actually a pediatrician, and my mom was wondering how to incentivize innovation in public health and prevention, not necessarily illness care. You talked about this in the beginning a little bit when you specified the difference between like insurance, care, and health in general.
Yeah, and just to kind of build on the question, I worry a lot that right now we have very strong incentives to make drugs for Alzheimer's. Why? Because if I was a pharmaceutical company making a drug for Alzheimer's, I'd be protected by patents, I'd be protected by exclusivity. Medicare would, of course, be the payer for a lot of those drugs. Medicare reimburses very liberally for drugs, and so there's strong incentives to make those drugs and bring them to market. But people in the room who are experts on Alzheimer's will say, one way to deal with Alzheimer's is not to discover treatments for it, but just to prevent it. And the things that prevent Alzheimer's may be quite different than the things that treat Alzheimer's. Maybe, and I'm speculating here, maybe the prevention of Alzheimer's has to do with walking more. Maybe it has to do with watching less television. Maybe it has something to do with obesity. How would we discover that answer? I don't think the pharmaceutical industry has the right incentives to discover those answers because those answers are not patentable, which is why I think the National Institutes of Health needs to launch a much bigger initiative on the prevention of disease, not just Alzheimer's, but the prevention of diabetes, the prevention of opioid dependency. And that's something that the private sector cannot do. And so I think we just need to spend more. Right now, the NIH's budget is about $30 billion a year. I would love to see that being doubled. It sounds like a lot of money, but it's actually infinitesimal compared to the $3.3 trillion that we spend on actually treating those diseases in the first place.
I would second that. I would note a lot of people in Silicon Valley are working very hard on this right now. I'm optimistic about their efforts. And in general, it's case by case. So some papers have suggested just having better data on which doctors are over-prescribing opioids could help a lot in solving the problem. I'm not sure we know for sure that's true, but we're not trying that many things yet relative to the escalation in the death rate. And there are a lot more things we could experiment with to try to rein that in that we're just getting started on.
Other questions?
Sorry, let me get my notes out.
What does your family member do?
Oh, no. This is just a question that I had.
I'd like to hear from a patient, actually.
So you both put a lot of emphasis on the importance of innovation. And so back in 2011, Dr. Chandra, you gave a TED talk titled "The Right to Spend, the Right Way to Spend on Healthcare," and you talked about proton beam therapy, and you called this the Death Star of medical technologies. And you've also talked about how this technology's effectiveness is unknown, but Medicare still covers it. Covers this expensive treatment, while we could have used this money to get an absolute return of covering more people. So my question for both of you is, do you think these spendings on new technologies that are not cost effective are, first of all, a problem, or do you think it's just an inevitable byproduct of innovation? And if you see this as a problem, is there a solution that could reduce and minimize this unnecessary spending?
So proton beam therapy, for those of you who don't know, is the single largest medical technology known to humankind. You build a cyclotron the size of a football field to accelerate a beam of protons. And the hope is that a urologist can take that very fine beam of protons and zap the cancerous cells in a man's prostate. Proton beam therapy has been shown to work for brain cancer, because with brain cancer you can spare a lot of the soft brain tissue. Luckily, there are very few patients with brain cancer. So, pediatric glioblastoma, very, very rare condition. However, people figured out that you can use this technology on men with prostate cancer. There are infinitely more men with prostate cancer, including all members of Congress, than there are kids with brain cancer. And so the technology is reimbursed handsomely by whom? By Medicare. So for the single payer folks in the room, I would say, you're going to have to deal with this challenge of proton being lavishly paid for by the single payer we have in the country right now called Medicare. Now, the private plans, Aetna, Humana, Cigna, begged Medicare not to cover this technology when it first came out. They said, this technology is completely useless. We don't want to cover it. But if you, Medicare, cover this technology, then we, the private plans, will have to cover it, because if we don't, we will get sued by patients saying that the government program covers it, but the private plan doesn't. And so guess what? Government completely ignored their pleas, went ahead and covered it. When I gave that talk in 2012, there were about 14 proton centers in the United States. That number is now up to 32. In Louisiana, hospitals have convinced the local legislature to issue muni bonds to finance the construction of proton, which is highly dubious medical technology. So in terms of how do we say no? Private plans know how to say no. We need to kind of get the Medicare program much more in the direction of Medicare Advantage, because Medicare Advantage plans are willing to say no to this technology. It's really Congress and fee-for-service Medicare that struggles to say no to dubious care. And if you don't say no to dubious care, you're sending an unambiguous signal to manufacturers saying, build more dubious care, because we will pay for it lavishly. So the innovation dynamics of paying for dubious care are actually quite large and colossal.
And in general, for a given level of public subsidy, economists tend to favor subsidizing basic research. That's what markets underprovide the most. Very general, groundbreaking innovations that maybe it's hard to get paid for at all. Subsidizing final outputs, we tend to favor the least. So any R&D decision, start with that general framework. You may need to modify it depending on context. But the highest returns often are at subsidies to basic research, not like final things.
We have time for one more question.
So my question for you is that we've established that both of you really believe in innovation, but we also know that humans are really bad at predicting the future, like really bad. So what happens if we're on the flat of the curve of the production and function of the innovation, and we actually don't move the curve out for like another 50 years because we haven't met that level of innovation?
If you look at past data, I'm not saying you can always extrapolate from the past to the future, but life expectancy has gone up for the most part, at a pretty constant rate for quite a while. So the default assumption, I think, is simply that that continues at a slow but constant rate. The last 2 years, actually, we've done worse than that. It seems most of that is opioids. I'm not sure all of it is. And in a lot of counties, life expectancy has gone down, which is nasty and surprising. There's an old saying, things are never as good or as bad as they seem to be. And I think in healthcare policy, that often tends to be true. We are a nation of people who muddle through. All our glamorous ideas, a lot of them are not going to happen. Other things will happen that we haven't foreseen. For the most part, this has been a better country, each decade than the decade before. And probably that will continue, and you'll see more decades of it than the two of us will. So that's the good news, and I close on that.
So I'm optimistic about the trajectory of innovation. When I spend time with VC companies who do a lot of this innovation, again, the innovation on the drugs and the treatments, the problem that they say they have is they just don't know what to bet on. I mean, it's just like really, really exciting. There's just like no dearth of really smart people trying to build things that can save other people's lives. So unless we do something terrible, like turn off our willingness to pay for those things, I think we'll always have lots of innovation in the years to come. What I worry about, I think what Tyler worries about, is confusing innovation in drugs and devices and therapies with innovation in public health. That second one is not going to be solved, I think, entirely by Silicon Valley. If Silicon Valley does it, it'll be through the goodness of their heart. But that goodness of their heart is not their core business model. So we do need a tremendous public effort in thinking hard about innovation in things outside of drugs and devices.
Thank me. Join me one more time in thanking our speakers.
Thank you.
Great, awesome.
That was a lot of fun.
Yeah,
Take
absolutely.
The show on the road.
I know, yeah.
Right?
Yeah.
Yeah. I thought that, but this was also very
than I expected.
jobs that I did.
Yeah.
My job. And I'm like, wait a second, guys. I'm giving you evidence on this thing. You're left with engagement.
Yeah.
Right? This is what economics is.
Yeah.
Not at Harvard.
I get name called less than you do, because people start off by thinking I'm crazy. And then when I'm like slightly sane, they're like, whoa.
Yeah, it's all in the updating.